Welcome to the Functional Neurologic Disorders Society podcast. I'm your host, Erica Cotton, coming to you from Chicago, Illinois, with a special thanks to Michael Romeo, our production engineer, coming to us from Australia, and our content curator, Ingrid Hertzauer, from the UK. In this episode, we have two guests, both esteemed board-certified neuropsychologists. Dr. Noah Silverberg is a professor at the University of British Columbia, and Dr. Ryan Van Patten is an assistant professor at Brown University. In this conversation, we discuss neuropsychological educational pathways and current training needs as it relates to FND, neuropsychologists' role across FND in both clinical and research contexts, and a topic near and dear to my heart, functional cognitive disorders and the role neuropsychologists can play in advancing the diagnostic understanding and treatment of FCD and FND more broadly. I'm so pleased to have you both. Thank you so much for talking with me today. Again, listeners, apologize in advance for any degree of excitement and or nerdiness that you hear during this episode, especially coming from me. I don't normally get to talk to my neuropsychology colleagues about functional neurologic disorders, especially functional cognitive disorders. So if I get a little too enthusiastic, full disclaimer and warning ahead of time for this episode. I'm thrilled. I hope you enjoy my conversation with Noah and Ryan, and I can't wait to get started. So with that, Ryan, why don't you start out by telling us a little bit, especially about how you as a neuropsychologist became involved in FND and especially functional cognitive disorders.
Sure. Well, first, Erica, thanks so much for having us. Thrilled to be on FNDS. I'm a big fan of the podcast. So bringing together neuropsychology and FND, Noah and I might rival you for some of the nerdiness and enthusiasm in this conversation. My own personal path to FND clinical work, teaching, and research as a neuropsychologist, I would say involved my very broad interests within neuropsychology, neurology, psychiatry, both clinical work and research. I've been interested since I started training in both the prototypical quote-unquote neurological disorders like Alzheimer's disease, TBI, and stroke, and also the so-called psychiatric disorders, depression, schizophrenia, somatic symptoms, and in learning about those conditions, doing research in some of them, I developed a perspective that neurology and psychiatry, sort of an artificial distinction, mind-brain, they go together more than they are different. And so those professions and disciplines being siloed sort of bugged me. And I like to think about, mental health symptoms and neurological conditions and neurobiology of psychiatric conditions and, maybe buck the trend in that way. So when I came across FND during some work in TBI and Parkinson's and epilepsy, I felt like it was a home and perfectly reflected my interests. It's such a nexus between neurology and psychiatry or psychology. You might say this for other conditions as well, but really with FND, you can't fit it into one bucket or the other. Like a lot of my work has been in functional seizures so far, where you have this primary neurological symptom, the seizure. Then you have frequent co-occurring neurological syndromes that come with it, like epilepsy and TBI. But as you both know, I know, the psychological distress in functional seizures and other FND subtypes, so common, contributing factors. Many of them are psychological in nature, like Bayesian priors, nocebo effects, trauma. So you really need both the neuro and the psych. And so it very much excited me, and I moved into it as quickly as I could.
I love it. I appreciate that your explanation highlights sort of the artificiality of the buckets we have created, right? We've created these separate silos, and that's not really how the brain or nature really seems to work. And I agree, FND perfectly highlights, you made these separate categories. Sorry, those don't apply here. Please rethink. Yeah, that's awesome. I love it. Noah, what about you?
Yeah, I had no exposure to FND during graduate school. I remember conversion disorder being scarcely mentioned as this rare and obscure condition we need not worry about. It wasn't until I started my career in neurorehabilitation and came across what both my rehab team members and I would describe as sort of confusing cases that were looking like stroke or TBI or neuromuscular disorders in some way, but not all things were adding up. And so we would often have agreement on the research team that there was something quote unquote functional about these cases, but the team culture was to not acknowledge that openly, not discuss it with the patient, sort of go about rehab as standard and hope for the best. And we were not getting great outcomes.
Listeners can't see my face, but I'm wincing as you're describing that.
You sure are. Yeah. So, I came across some colleagues, probably John Stone's earlier writings and sort of brought these to colleagues with some excitement, suggesting that maybe we should try to do some things differently. Some were open to experimentation with what I would now consider FND-informed care, starting with communicating the diagnosis transparently, focusing on retraining and offering psychotherapy as well. And got some better outcomes. So I spent more of my clinical time over the years seeing patients with concussion or mild traumatic brain injury, where I was seeing a lot of what looked to me like overlap with FND, especially functional cognitive symptoms, but kind of harbored that idea for a few more years as my research program was getting going, and realized that a lot of the constructs that we were studying in people with persistent symptoms after concussion, like anxiety, avoidance behavior, attachment, etc., were all over the FND literature. And it wasn't until I was on a visiting professorship in Boston that I worked up the courage to reach out to an FND expert, David Perez, who you probably know and many of your listeners know, and sort of brought this idea that, hey, there seems to be a lot of overlap between concussion and FND, especially functional cognitive disorder. What do you think of that? And he was like, yeah, obviously, and sort of encouraged me to take my research program more in that direction. And that's what we've been up to for the last few years.
That's amazing. Yeah, David's amazing. David Perez just has such a instant grasp of all the different aspects, neurologic and psychiatric, and such an openness to conceptualization and patient care. I enjoyed our recording with him very much, and I really enjoyed working with him. Yeah, he's a great FND ally for sure, especially for anyone who's like quasi interested in it or thinking about it. He's like, oh, definitely come join us,
Yeah, so encouraging.
Yep, you have a home here. It's great. I want to take a step in a further direction and talking specifically about neuropsychologists in the clinical role. And Noah, you touched on this by noting that I think as neuropsychologists, I probably had the same training experience as you, right? Like conversion disorder is like minimally mentioned in passing, almost sort of brushed aside or nearly avoided, somewhat akin to malingering, and just don't worry about this. Forensic people might need to think about this, but us, it's not an us thing. And so I really appreciate your publication and your narrative review of neuropsychology's role in functional cognitive disorder specifically, but also just your thoughts in general about neuropsychologists' role in FND and how we might even change our training program to be more reflective of that. Because I think that is a big limitation. I mean, certainly I can't imagine our boards asking a question about FND, right? It would just seem so inappropriate. But then when I think about it, I'm like, what we should be, because who is better suited to really be talking about these gaps, or especially a condition that has such brain-body overlap. But I'm just so curious for your thoughts. And I want to commend you for taking a leap and saying, hey, neuropsychologists should be involved in this.
Yeah, and historically, we as neuropsychologists have not led the way in this field. I think we've been quite slow actually to get on board, but I've come slowly to the same opinion that you have, that we're actually very well suited to play an important role in FND care, and may even go as far as to say you can't spell FND without neuropsychology. Well, you can. There's this ongoing sort of litany of complaints about this divide between neurology and psychiatry. And as Ryan mentioned, that's where neuropsychologists live. And I think we have unique contributions, including things like standardized and thorough cognitive assessment. What we do have training in case formulation that integrates biopsychosocial factors, and in providing the kinds of behavioral interventions that I think are a good fit for many of these patients. But yeah, we probably need to start back with graduate training and have some of our coursework. Like we all take courses that cover various neuropsychiatric and neurocognitive disorders. FND is not among them, but really ought to be. And I think just more intentional exposure clinically during externships or residency to FND cases. And sadly, I think looking back, I probably did see some FND cases in my training. I just didn't realize it, and probably my supervisors didn't either.
Yeah, exactly. I think I was surprised as well when first getting into the FND field how alarmingly absent neuropsychologists were. It's kind of been led by neurologists and a handful of psychiatrists up till this point. And I think as awareness is growing, different people are becoming more and more involved, especially neuropsychology. And I'm grateful that, even coming up, there's been some invitations to talk about FND, right? Like AACN coming up, as having FND be part of the conferences. And it's been ironically FND's been more present at the neuro conferences I've attended, right? Like AES, right? AES always has like a functional seizure sick or like functional movements within the Movement Disorder Society. But within like our, neuropsychological societies, it's been not present. I'm thrilled it's coming up on some of the programs. And the same thing with the teaching guidelines. I agree completely. We get our standard conditions, right? The standard movement disorders and epilepsy and strokes and TBI. And these are the neuropsychologist's realm. And then there's the other mood disorders, but FND is not in either of those mentioned, in either of those curriculum. And I'm also thinking ahead to, what is it? It used to be the Houston Conference Guidelines. Now it's the Minnesota Conference Guidelines for our training guidelines. Maybe in the future, I guess 5-year plan would be to influence those guidelines and training guidelines and hopefully expand training access to it. But we need publications, and I think we need neuropsychologists saying, hey, I'm a neuropsychologist, I do this. This is helpful, which I think is great that you are so involved in neuropsychological work focused on FND. The same thing with Ryan. So Ryan, you've started out sort of claiming FND as a significant area of clinical and research interest sort of right out of the gate as an early career neuropsychologist, which I don't know, you guys are rare species, coming out of the gate saying you want this to be such a central role. Ryan, why don't you talk about and tell our listeners about what you're studying in FND and how you think that neuropsychology kind of complements that and provides a good background for helping this population.
Yeah, happy to. I should also give a shout out to Bert LaFrance, who I know we all know. And as an early career person, he's been a senior FND researcher and clinician who I've learned a lot from. He's really mentored me in the early years, as have many other folks that I appreciate.
Sorry to interrupt, Ryan. I think Kurt LaFrance, as a neurologist psychiatrist, has probably trained more neuropsychologists on FND than other neuropsychologists have trained neuropsychologists on FND, right? Because he trained me. I know he's been involved with Noah's work too. It's just like, I think Kurt probably gets credit for training a lot of neuropsychology on FND.
He's an honorary neuropsychologist.
Yeah, he really is.
Neuropsychiatrist, we are very closely aligned.
Yeah.
So, one thing that comes to mind, some research I've been involved in, and then piggybacking off what Noah said, certainly neuropsychologists have a role in functional cognitive disorder. I think we'll probably talk about that. That is and or will become clear. Something that might be less clear to some folks is just how common cognitive concerns are in people who have so-called non-cognitive FND or functional movement disorder, functional seizures. Cognitive symptoms, some data suggest, are one of the most common symptom categories reported, maybe after fatigue, along with pain, that sort of thing. So even if it doesn't have cognitive in the name, I think cognitive symptoms, and we're learning more about what neuropsych testing shows in these folks, but having problems with cognitive functioning is cross-cutting, transdiagnostic for us, which I think really paves the way and makes it clear that neuropsychologists have a role here. A few other sort of characteristics that we have, or strengths, I think, that neuropsychologists can bring to the table when it comes to FND would be psychometric training. in reading some of the FND literature, selecting outcome measures is a big area of interest that's challenging. There are discrepancies between subjective and objective scores, whether it's in cognition or physiology or other areas of functioning. And so our background in that regard can be helpful. A lot of interest, rightly so, in FND versus feigning, the differential diagnosis there, how they are different phenomena, and neuropsychologists having knowledge of performance validity tests, symptom validity tests, assessment in general can be, really useful, I think, and contribute on interdisciplinary teams. Yeah,
amazing highlights of, I guess our psychometric background is quite unique, right? And that highlights a need, I think, throughout the FND literature of outcome measures, right? There just aren't good outcome measures. There aren't good symptom measures. It's really hard to even capture and identify symptoms and symptom changes, let alone in something like cognition. And you're right. I think it's like some estimates are as high as 80% of people with FND report cognitive symptoms as a major complaint or a major comorbidity. Which really just kind of begs, all right, then where are the neuropsychologists in this, if there is this cognitive concern? But that's a great segue into talking about, especially for functional cognitive disorders, and cognitive disorders relative to certain populations, like traumatic brain injury or post-concussive syndrome. In terms of neuropsychologist's role, I'd like to start hearing from Noah about his experiences working with post-traumatic or post-concussive syndrome, and the overlap with FCD and how you view those as separate, distinct, the same etiologies, and talking with our listeners about what might be the same or different.
Sure. So I've come to view functional cognitive disorder as a probably common, but we don't have good epidemiological data, so I have to qualify that, complication of concussion. So it's quite common for adults who have persistent symptoms after concussion to have cognitive symptoms, difficulty concentrating in memory, be among the most prominent. And that's kind of how I came to this field of FND and FCD, is like through the lens of persistent symptoms after concussion. So some of our earlier studies were focused on not FCD per se, but more on persistent cognitive symptoms in the context of concussion. And we were finding things that, again, pointed us back over and over again to the FND literature more broadly. If I may, I just want to, before I review some of that work, give a shout out to some of our graduate students who were involved in it, including Mathilde Rioux, Edwina Pecan, and Xian Shi. So, some of our early findings were that memory for instances of forgetting were preserved in patients with severe memory concerns. We found that memory perfectionism predicted the severity of memory concerns more strongly than objective neuropsychological test performance. We found that catastrophizing was also related very strongly to the severity of memory concerns and the discrepancy between subjective and objective functioning. We looked some at coping strategies like avoidance of normal memory use and repeated checking, to make sure the door's locked and the stove is off, and those things seem to be associated with worse cognitive concerns. And then we also had some dead ends, like studying metacognition, at least as measured by how well memory confidence and memory accuracy line up on kind of a trial-to-trial basis that did not seem at all associated with persistent cognitive symptoms. So still trying to figure this out, but those were some of our kind of early impressions.
Yeah, and the overlap with constructs and theoretical frameworks for FND broadly just map on so well to post-concussive symptoms. And for our listeners, just to highlight, so when we're talking about functional neurologic disorders, I'm sure most of our listeners know there's several subtypes: functional seizures, functional movements, persistent perceptual postural dizziness, triple PD, and then functional cognitive symptoms, although functional cognitive symptoms are not yet a recognized DSM subtype. We are working on that. And the distinction, which I've always found very interesting, is in functional seizures or functional dizziness or functional movements, there is sort of this external observable characteristic that is the quote unquote target symptom. But in functional cognitive disorders, we get really meta, where it's essentially a cognitive symptom within a functional neurologic presentation where the symptom is the thought, and then it's the thought about the thought or the thought about the cognitive performance without this other external, easily identifiable symptom. So it can get a little hairy when we start to talk about functional cognitive symptoms and what's a symptom versus just a thought versus some other self-observation. But especially for something like persistent symptoms after a concussion. Sorry, Noah, there's a correct terminology, and I'm probably not using the right one. Persistent symptoms after post-concussive syndrome,
there's some ongoing debate in the field as to a preferred term there. So you're safe. I tend to use persistent symptoms after concussion.
Okay, but, good. All right. Thank you. For persistent symptoms after a concussion, I often, and Noah, correct me if I'm wrong, but I do believe there are also frequent physical comorbidities such as ongoing dizziness or some movement episodes, and sometimes even frank FND overlap with like functional seizure episodes or functional movement episodes. And so characterizing the different reasons for the development of different FND subtypes or features, again, we artificially create these labels, and then nature says we don't care, and then people just have a whole range of them, and we label them something else. So there is this really significant overlap between FND broad spectrum symptoms overlapping with post-concussive symptoms, which is a real prominent area in neuropsychology, as well as functional cognitive disorder specifically, and how persistent symptoms after concussion or concussion might be one way that someone develops a functional cognitive disorder versus a very similar subset of symptoms after viral illness or after another sort of infection or after a different sort of event other than head injury. But I think that's just something important to highlight for our listeners as well as for us to be aware of within our field. I think it does make research a little complicated in terms of saying, this is who we're including, this is who we're excluding. But I think keeping in mind and an open mind across conditions is really useful. And I think that's been a major strength of your work, Noah, is pulling so much from the FND literature into the work with persistent symptoms after a concussion.
Yeah, and to your point, Erica, I think FND and FCD following or precipitated by concussion or head injury is probably the same thing as FND, FCD following other kinds of precipitants. So we need more studies to understand how well things generalize, but that seems to be how it's shaking out so far.
Yeah, and one other piece of your work, Noah, that I maybe I'm just not in the right group of neuropsychologists to have this. I was sort of more in my training, but the use of, one, you're definitely a primary researcher as well, but primary researcher of intervention outcomes, right? I just feel like neuropsychologists don't really do as much intervention. At least a lot of my colleagues are like, nope, I wrote the report and now we're done and goodbye. And, it's two visits max with the patient. And the fact that, I even want to talk to patients for longer is kind of seen as an anomaly. I think if we're in a rehab setting, that's a more acceptable realm for neuropsychologists to have a continued ongoing treatment relationship with a patient. But in non-rehab settings, it's kind of atypical for neuropsychologists to do interventions and especially have treatment studies and outcome studies like a randomized control trial looking at the effectiveness of an intervention, which is, you seem to have just taken that role quite naturally. And was that part of your rehab training, or is it more common in Canada for neuropsychologists to do intervention? Are you all nicer to patients, or are you like, oh, I want to keep talking with you and helping you?
I'd like to think nicer. I'm not sure if that's true. I think it has more to do with being in a rehabilitation setting where, the expectation is we don't just assess and provide an opinion, but also treat. So as a clinician, I spent probably at least half my time in treatment, which, I gather outside of rehabilitation is an unusual mix for a neuropsychologist.
Yeah. And maybe that's also partly why, FND is not well represented among neuropsychologists, right? If a big part of our role and something we can bring to the table is treatment intervention, right? Which might be more of a rehabilitation neuropsychologist or more quote unquote traditional psychologist who provides intervention, that we're just not capturing that. the role is an assessment and not follow-up when really these people need a lot of follow-up and intervention, which is a great segue, pulling in Ryan's background and interest as well, because Ryan, you're also heavily involved in a Veterans Affairs system where I think a more multidisciplinary, comprehensive rehabilitation approach is often utilized with patients. Well, maybe I'm wrong, and the system might say different. At least that's the aspiring approach in the VA setting. I'd love to hear also your input about, FND and TBI, especially in veteran populations where there's just higher rates of traumatic brain injury, different comorbidities, and a different system, right? It's a different systemic involvement in neuropsychologists' role and openness to FND in general.
Sure. Starting broadly and thinking about FND and TBI and veterans and civilians, first, I've learned a lot from Noah's work, and a lot of progress has been made. Something that strikes me that Noah's really taken the lead on, I think Mike McRae has done some of this as well, as when we think about persisting symptoms after concussion, bringing in psychological factors and how important they are for civilians and veterans. It's actually another good example, similar to what we were talking about earlier, of neuro plus psych together. TBI traditionally seen and thought of as head injury, mechanical, neurological. It goes into that bucket. But as we know, there are a lot of expectation effects that contribute to TBI being the precipitating factor for the development of FND or FCD. There's often, when people have a concussion or a mild TBI, there's a lot of context surrounding the event, like fall or a car accident, distress. It's an emotionally laden experience, and there can be nocebo effects, expectations that something's wrong with my brain, I have brain damage. There's the societal impact of CTE and expectations for brain disease following a concussion or two, all of which I think some of this work has happened at the VA. Not all of it, though. Certainly when it comes to CTE, sport concussion research has contributed a lot. I think it just really stands out to me, the importance of these psychological factors in linking TBI and FND, FCD. If I sort of zero into VA, veterans, and TBI, and thinking about, at least my work has been with U.S. veterans. One person I should give a shout out who's done great work in this area is Martin Solinsky. So thinking about veterans and some of the most common injuries and illnesses that they face and grapple with, TBI and PTSD come to mind, right? And these are two really big risk factors for developing FND. Yeah. So it's
even
not
non-veteran,
surprising.
Right? And in non-veteran
Sure.
populations as well, just PTSD in general is a risk factor, right? And our nation's veterans just have such high risk for PTSD. Yeah.
For sure. Anyone with TBI and or PTSD trauma broadly would be at increased risk for FND later. Erica, I like what you mentioned earlier about thinking of TBI as sort of a similar risk factor, precipitating factor, similar as long COVID, viruses that people make, surgeries, vaccines, depending on the negative expectancies that might go on, and some of the immune effects of some of those conditions. So those can precipitate. A little bit about TBI, FND in veterans. A lot of this work has been in functional seizures specifically. Certainly Martin Solinsky's work has. I think it generalizes pretty well in other areas. So veterans who have both functional seizures and TBI have worse outcomes than veterans who have functional seizures without TBI. Some specific research on this, like vastly increased risk for depression, disability, cluster B personality traits. They just, as you might imagine, the combined effects of two different brain syndromes can make your experience a lot worse. And if you have seizures and TBI, I think that just adds to the potential expectation for negative cognitive and mental health effects, you sort of have two brain diseases or two insults that might lead to expectation for later problems. So it's complicated. There's a lot going on for many patients with FND, including veterans.
Yeah, I think you're highlighting especially that veterans are at such unique risk for having risk factors for traumatic brain injury, risk factors for then comorbid traditional quote unquote neurologic conditions, right? Like developing epilepsy from a post-concussive injury or just repeated head injuries. And then because they have a history of head injury and seizures, they're at greater risk for developing functional seizures, right? And because they're on medicines, et cetera, and because they have PTSD and an exposure to trauma, then they're at higher risk for having functional neurologic disorders as well. So it's just like this compounding effect of these very significant and complex overlapping features that I think neuropsychologists are really well poised to ascertain, describe, elucidate, and document the nature and severity of. I do think in general. Oh yeah, Noah.
And treat, if I could add. So just circling back to also your question about training in neuropsychology, if we want more neuropsychologists involved in treatment delivery, I, for one, would advocate for more broad-based kind of training in clinical psychology. I find nowadays some neuropsychology programs are pretty focused on more assessment diagnostic stuff, whereas I certainly credit my interest and work in clinical trials to some of that early training in like different therapy modalities, including psychodynamic. And I did rotations during my residency, for example, doing exposure and response prevention with OCD, getting my patients to try to lick doorknobs and so forth. And
no wonder you're so interventionist. That's hardcore interventionist. You are not your normal neuropsychologist.
Well, I think that kind of training definitely helps, and would just encourage others to consider keeping their scope of training broad, at least until they're certain that treatment does or doesn't interest them in their future career.
Yeah, I think that's a great point. No, I've often felt similarly because my background obviously is a PsyD, which is different than the PhD. And the main distinction being it's a much greater focus on clinical care, right? So rather than being in a research lab where I had to answer a very specific research question and do all of that, it definitely shows if I try and do statistics. However, what I did get broad training on was how to be a psychologist, right? Like broadly, like DBT groups and that kind of thing. And I found that that's actually been so useful when it comes to working in providing interventions and working with FND. It's just, I do question or hope, like sometimes I think our field has maybe gotten a little too hyper-specialized. And too hyper-focused early on. I know for me, and when I knew I wanted to go into neuropsychology, like that was my declared track from the beginning. And like every single one of my internships, was focused on that. And I had these extra experiences. Unfortunately, my internship was in a rehab setting, which is very intervention friendly. If I didn't have that, I might have become, just a siloed assessment provider, which is a perfectly fine career path to take. But I'm just wondering if more people were exposed to it earlier on. Even I think a great group is also like behavioral medicine students, right, who are exposed to other classically medical populations, right? If we got them exposed earlier on to brain-based conditions and especially FND, I think they might be really well poised to be great providers for this for this specific condition. And absolutely. I'm so glad to hear you're an advocate of that.
That experience too, certainly through training. One thing that comes to mind is the culture of becoming a neuropsychologist. Part of what happens in my experience is, we are clinical psychologists first, and then we specialize in neuropsychology. Part of that specialization involves developing this identity where we are different from some other clinical psych trainees and providers who really focus on psychotherapy. And so some neuropsychologists might think, oh, this is what, we do assessment, the therapy thing in grad school and internship and postdoc. That's what, people focusing on trauma and depression. That's what those other clinical psychologists do. We do assessment. And of course, as we're talking about throughout the conversation, these dichotomies often are helpful. There's no reason why one cannot do both assessment and therapy. And also, I think that this has been changing slowly over time, particularly with cognitive rehabilitation becoming more popular within neuropsychology. then again, you might have the distinction between cog rehab, like the people sometimes do memory strategies, compensatory cognitive rehab, or restorative rehab, computer-based, that sort of thing. Distinction between that and traditional psychotherapy, whereas I would say when it comes to FND and a lot of other conditions, neuropsychologists need not confine themselves to only one of those categories or the other. I think good interventions, like some for functional cognitive disorder that are developing, have emotional, quote unquote, psychotherapy components, but it's also a brain-based disorder. So you need to have, neurology, cognitive, neuropsych background, in which case it does fit within our identities.
Yeah, you're so correct. And for our listeners who aren't as familiar, I'll hopefully my background does these guys justice, but I would like to highlight both of my guests here were very modest with how they wanted to be introduced. So I'm going to highlight that I'm speaking with two board certified neuropsychologists, one who engages in treatment with a population that has a huge functional neurologic overlap. If not, we could label it that, as well as randomized control trials of treatment outcomes for that, which even for FND, treatment outcomes studies are particularly rare. And then the other who is actively pursuing a career defining the cognitive features of FND and advocating for that. So these are pretty pioneering guests that I have on the show who are being remarkably modest, but also are really great role models, I think, for future clinicians. So in terms of building out having this model and demonstrating that you can be a really good neuropsychologist while still engaging in these aspects. On that note, let's put our neuropsychologist involved in FND role to good use and talk about the diagnostic criteria for functional cognitive disorders, because I feel like as neuropsychologists, we should just be heavily involved in defining this condition. So there's the 4 criteria, right? 1 or more symptoms of impaired cognitive function, internal inconsistency with observed measure function or between different situations. We can definitely talk about that. Symptoms not better explained by another medical condition, and symptoms causing clinically significant distress. 1 or more symptoms of impaired cognition and internal inconsistency. As neuropsychologists, we should be pretty heavily involved in how each of those are being defined. Obviously, we can play a huge role in saying that, these may or may not be explained by another medical disorder as well, given if another medical condition is present and they have cognitive impairment and it looks like that's a very plausible explanation, it would be neuropsychologist's role to generally say that. But I'm curious what you guys each think of those criteria, next step for those criteria, and how we as neuropsychologists might contribute to establishing these criteria and maybe even getting those in the DSM.
Yeah, I'm happy to start, if that's okay. So I think of the criteria you listed there, Erica, the internal inconsistency is really at the core what makes the diagnostic criteria kind of unique, and is a concept that I think could use better kind of operationalization. I understand in principle it sort of mirrors the diagnostic criteria for other FND subtypes, but as you mentioned earlier, we don't have the equivalent of like a Hoover's sign that's used in functional weakness for functional cognitive disorder. Instead, we're relying on often kind of softer signs, things like discrepancies between what the patient describes their symptoms and how they present an interview, like the fact that they can speak fluently and remember details from recent events. And to Ryan's point about training in psychometrics, I worry about like the inter-rater reliability of that, relying too heavily on that sort of a thing. I think as neuropsychologists, we have the opportunity to perhaps better define internal consistencies. For example, looking at specific patterns within neuropsychological testing, but I don't think we're there yet. The so-called Hoover's sign for FCD still eludes us.
Yeah, Ryan, what do you think?
Completely agree about that. The diagnostic criteria paper that we're using for functional cognitive disorder published in 2020, right? Harriet Ball and colleagues. So I think it's great that we are sort of reconceptualizing these issues within an FND framework. cogniform and some older terms, diagnoses, and ideas. It also will take time. Yeah, Noah, in your TCN paper and some of your work, the critiques of areas of growth for the FCD diagnostic criteria make a lot of sense to me. There's a lot of work to be done in FCD broadly. As you said, most FCD diagnosis these days is based on history, interview, behavioral observations, which is all fine. But when I talk to people about functional cognitive disorder, and then I get to a slide or a part where we're talking about cognitive testing, and there's so little available, people are neuropsychologists and trainees are often very surprised. Like functional cognitive disorder and neuropsychologists haven't always been that involved, and we don't know that much about the cognitive profile of this condition or the long-term outcomes. Like if we're differentiating it from a degenerative disease, we think there's a lot of potential fluctuations in the timeline, temporal progression of FCD, but we don't know. There's not a lot of longitudinal research on this. There's just so much. The underlying mechanism, Noah, you had referenced memory perfectionism or metacognition. I think there's so much work to be done in some of these areas to better flesh out FCD, which will then contribute to us updating, refining the diagnostic criteria.
Yeah, that's such a great observation, Ryan. In terms of, for just our listeners to take a step back, I think when we talk, we've done the overview of FND, right? Functional seizures, functional movements, triple PD, and functional cognitive. And I think traditionally, neuropsychologists' role within FND has been defining comorbidities or ruling out the presence of other neurologic contributions, right? Like, is this due to an early neurodegenerative process, or is this consistent with traditional aftermath of a traumatic brain injury or a concussion, right? And so assessing comorbidities, defining if the symptom severity matches, or at least the cognitive profile matches these other conditions, and ideally, with more training, providing intervention for functional seizures and functional movements, because we're skilled too, and can explore that. But I think specifically for functional cognitive symptoms, all the areas both of you guys just touched on and all the research in this is our area, right? Like, what is a cognitive symptom? What are we saying cognitive is, right? We as neuropsychologists can't define a movement disorder, right? We are not qualified to look at a movement and say whether or not it's functional or it's consistent with Parkinson's disease, right? We as neuropsychologists are probably the best people. I don't know. Are we the most? I think we should be considered the most qualified people to say this is a functional cognitive symptom versus a non-functional cognitive symptom. And here's why. I mean, are we going to leave that to neurologists or psychiatrists? I don't know. Not that I'm sure they have some ability, but shouldn't we be the best ones to do that? And I think there's just such a opportunity for us to talk about and make these definitions, because functional cognitive disorder really brings all this in this very meta way. Well, this aspect of their thinking and cognitive profile is functional. This aspect might not be. And how we're defining all of those pieces, even from within the definition, like you said, Noah, of is it the discrepancy between subjective and objective? But then what about a person who says, no, I'm still above average and their test scores are above average. So there's no technical discrepancy, but they're still distressed as all heck by a subjective decline, right? But I'm not as good as I used to be. Or when I do now not remember the date of whatever, so-and-so something, that's bad. And they get so distressed by it. But technically there's no discrepancy. So do they meet criteria? It's ripe with definitions and criteria and exploring these elements and emotional versus cognitive reactions and cognitive processes.
Yeah, at least in a room of neuropsychologists here, I'll agree that, we should be at front and center of, of all of this. Just to the last point you made, that's something we've been wondering about as well, because it's common, as you know, for people with FCD to say, for example, well, my memory was excellent before, photographic even. And so they perform, quote unquote, normally on neuropsych testing. So we interpret their memory, at least under certain circumstances, as functioning normally, and that maybe their reflections on how their memory used to be is subject to a good old days bias. Or maybe they're right. Maybe it's people who have particularly good memories and their identity is especially wrapped up in their good memory that are at risk for developing FCD, because if it starts to function abnormally, they're going to be very concerned about it, more so than people with, say, an average memory. So, yeah, I don't think we have answers to these questions yet, but I think these are great areas for ongoing research.
By neuropsychologists.
Yeah, you said
it. Yeah, I don't know if either of you had this experience, but when, I got trained in neuropsychology, right? And we get trained in all these cognitive versus emotional. I'm like, wait, why are these different? Why is anxiety or depression or some sort of emotional response not considered a cognitive process? I was like, is it not in the brain? I don't know. Like, I always just took cognitive to imply, coming from the brain, and as if emotions are somehow not. So I always took issue with that, but I've accepted I need to embrace the terminology. But then, as when we learn our testing, we get all of these tests for their cognitive processes, attention, language, memory, and we get like 14 subscales to look at how they attended to something or like how they remembered something. And then when it came to emotions, what we've got is like, are you sad? Question mark. And no assessment of the process of how they became to be sad. What is their, perception of sad? Is their perception accurate in response to certain things, right? It's like, that would be the cognitive equivalent of asking someone like, do you have problems with your memory? Question mark. Right. And that's that was just such a marked discrepancy where we are at this self-reported symptom outcome as it relates to mood, emotional functioning, self-awareness, self-observation, like sort of self-descriptions, like self-reports, versus from a cognitive process level. We can analyze 18 ways to Sunday if, their retrieval memory is distinct from their level of encoding, which is distinct from, at a statistical level, different from their level of recognition and retention. And I'm just like, man, should we be mapping out better emotional tasks or better emotional process tasks to really define that and come to a better understanding of what's happening? Or should that be more on our traditional psychologist colleagues? But I was just like, man, is it not present, or do we just not use it as neuropsychologists, or do we just not care about that? But I think it's specifically for FND, where someone's emotional reports might not really match the underlying experience given the high rates of alexithymia, or just the role and high relevance of that emotional dysfunction as it relates to symptoms. I feel like we should be doing a better job, but I don't know if that struck either of you, if I'm completely unique by this.
I think we should and can do a better job, but it comes back to this kind of discussion we were having about broad-based clinical psychology training. So psychological assessment involves more than a mood checkup, right? We should be assessing for things we know now from research evidence that are important, things like illness, beliefs, and maladaptive coping, and those kinds of constructs should be a part of our case formulation that goes into our report and becomes a subject of discussion in feedback sessions, and really sets a patient up potentially to have a more kind of coherent understanding of their condition and be ready to engage in psychotherapy.
Yeah, exactly. And I think going back to, just the field standard, can you imagine on boards I think even the case reports that I submitted, like a BDI and a BAI, were perfectly sufficient for a complete emotional assessment, right? And if we actually had to have like a psychological conceptualization of this person's psychiatric complexity, their coping resources, recommendations for improving mental health aspects, but I feel like everyone kind of picks the cases that are, well, here's their clear neurologic complexity and how it impacts their cognition. And we assess mood and it might influence it, but we're not going to say how or why, and can you imagine where if someone actually submitted a case where it's both are present and were robustly assessed, or that was even a requirement? To me, I'm just like, oh no, that doesn't feel like being the right.
You're going to go with the safe ones.
Right. Totally. What do you think, Ryan, about our field's approach to the assessment of emotion, if that's the correct way to phrase this problem?
Yeah, my mind goes to the FND world, and I think a big part of what you're getting at, Erica, is this idea of social cognition. Whereas we sometimes are thinking of cognitive functioning as being cold cognition, so to speak, our traditional and well-loved cognitive domains like working memory, attention, executive functioning, language, which are very important. But then over there, you have emotions like depression, anxiety, etc. I think an area of growth and a lot of cool work is starting to be done there is putting those things together. Susanna Pick has a really cool 2020 paper, I think, all about neurobiology of emotion in FND, including outcome measurement of those things, which I think, yeah, we need to be doing more of as neuropsychologists generally and in the FND world specifically. Another way to bring in emotional symptoms that comes up a lot for me clinically, if we go back to the diagnosis of functional cognitive disorder, like we were talking about earlier, there's several tricky differential diagnosis situations that neuropsychologists can get in when it comes to FCD. And as you mentioned, Erica, FCD is not a recognized subtype in the DSM-5, so it's not diagnosis for billing so much, but when we're formulating around what we think is central for our patient, one of the tricky situations that I hear about and have experienced is, my patient doesn't have a degenerative disease. It doesn't look like. They don't have severe TBI or stroke. They have cognitive problems. They have a lot of mental health conditions and symptoms, depression, anxiety, somatic symptoms, maybe PTSD, that sort of thing, and they have cognitive problems, and they're concerned about their cognition. Is that FCD, or is that cognitive problems secondary to mental health symptoms? And are those things, how different are those two phenomena? Would I, at least clinically, in a more sort of practical, writing an impression section, giving feedback to a patient, and case conceptualization, the way I tend to think about this, maybe improved FCD diagnostic criteria in the future will help. But I lean more toward FCD in folks like the case I described, if the majority of that person's distress centers around their concern about their brain and cognitive problems, and FCD feels like more at the center of the bullseye, or cognitive concerns feels like the center that are sort of maybe leading to problem sleeping, worry, anxiety, feeling down, not working, etc. On the other hand, when you have cognitive problems that seem to be more resulting from depression and anxiety, and the emotional, so to speak, the mental health symptoms might center around other topics like worthlessness as a person, uncontrollable general worries, panic attacks, that sort of thing, then I lean away from FCD. Of course, it's a continuum, and I don't want to suggest putting people in buckets or that it's black and white, but the degree to which we are deciding, is functional cognitive disorder something I want to really make central in my conversation with this patient? Might they benefit from thinking about what's going on with them in terms of FND? Might they benefit from FND resources like neurosymptoms.org, or some of the interventions we have that we can tailor to them? Those are the situations when I lean more toward formulating around FCD.
Yeah, exactly. Noah.
Yeah, I really like what you were saying there, Ryan, about considering what would be helpful for the patient and kind of working backward from there. And I think the point you were making is that, are we conceptualizing in a given patient whether their cognitive symptoms are a cause or consequence of their emotional distress or psychiatric comorbidity? So in clinical trials, we've been sort of forced to clearly operationalize what these criteria actually mean. For example, the not better explained by criteria. So lots of these patients have depression or anxiety disorders, but when does that fully explain their cognitive symptoms? And I guess clinically as well, if we ask ourselves the question, theoretically, if I treat the depression, will their cognitive symptoms go away? Is one approach to trying to make that distinction.
Yeah, exactly. Or how well does it even respond to simple psychoeducation, right? If someone comes in with cognitive concerns and it's one of many and maybe not even a focal concern, and a 15-minute explanation about how depression is part of the frontal networks, and that pulls attention away from these brain regions, and that means that you're going to be less efficient. This is a completely normal symptom to have with depression, and not something to think about like feeling tired or sad. It's just another common brain manifestation of it, and people are like, oh, okay, yeah, all right, so now I don't have to be worried. Now I can just be depressed, right? And have that be central and reassuring versus no, you don't understand. This is bad. This is not depression. This is worse than depression. Or I've been depressed my whole life, but I was able to work, right? I could go to work when I was depressed. Now I can't work because my brain lapse, I forgot this thing. I'm losing track of things at work. I'm worried I'm going to make a mistake, right? And making those distinctions for people. Yeah. Bringing it back to patient-centered care, I think a future discussion, because we are out of time and I want to be mindful of everyone's time. And something I think for us to continue to focus on as we're being trained as neuropsychologists is back to that patient-centered model of, do we consider FND a patient population for neuropsychologists, right? And advocating for that patient, because we get trained of how to talk about stroke, how to talk about movement, how to talk about epilepsy with patients, how to assess it, right? It's one of the acceptable things we can submit for boards, to say that we're a good neuropsychologist. But I think maybe advocating for FND as a valid population for neuropsychology is a great way to move forward. I'm just envisioning future training guidelines involving FND being written by you guys. And I think that would be a great next step. No pressure, no pressure in addition to all of your other demands.
Ryan will
take it. We're going to rope you in. No, we're going to rope you into that, Erica. It's not just us. It's all three of us.
Oh, I think that would be a wonderful next step. Well, this has been excellent. Hopefully our listeners learn a little more about neuropsychologists, but especially about neuropsychologists' role in FND. And more importantly, gosh, I don't want to say we've dropped the ball as a profession on FND. We're just a little slow to pick it up, maybe. And there are some people who are, experts on FND and just, point guards when it comes to FND in the neuropsychology field right now, my two guests especially. But within neuropsychology, there's still a lot of players who are real hesitant to even pick up the ball and go there. So I think maybe we can work towards changing that over the span of our careers here. But hopefully our listeners now are a little more versed in neuropsychology and neuropsychology role, and maybe a little more understanding why their neuropsychologist colleagues are like, no, FND, I don't do that. But hopefully it can be encouraging as well. Be like, hey, do you know Kurt LaFrance? He could probably train you and get you real comfortable with FND. Oh, you guys have been awesome. I've really enjoyed this. I think our listeners will too. And thank you so much for taking the time, but especially all the work you're doing. It's just so awesome to have neuropsychology be involved in FND, both from my identity as a neuropsychologist, where I'm like, yeah, these guys are doing it and it's awesome, as well as from within FND. I'm like, yeah, there's neuropsychologists studying this. This is great. Like, outcomes are going to be better. We're going to make progress. So thank you both for your contributions and taking the time to be with me today.
Thank you for being a voice for our profession, quite literally. Yeah.
Oh. Thank you both. Okay, take care. Physicians and providers treating functional seizures, we invite you to participate in a brief survey examining driving recommendations for patients with functional seizures. Developed by a dedicated study group, this survey seeks to capture the current opinions of physicians worldwide on this topic. Please take a moment to share your experience. A link to the 5-minute survey can be found in the show notes.